Hello, everybody. Welcome back for another episode. So excited to have you with us and with our special guest, Dr. Michael Villa, who's an associate professor in the Division of Endocrinology and the director of our Multidisciplinary Thyroid Center, which opened a couple of years ago here at Mount Sinai in Union Square. Thanks for joining us.
Great. Well, thanks for having me. I'm happy to be here.
So maybe we should just start at the beginning. Tell me a little bit about what the thyroid is, what the thyroid does, why we should care so much.
Sure, absolutely. Well, the thyroid, I think about the thyroid a lot, of course. It's a gland. It's located in the neck, right in the front of the neck. And it's a very important gland. It produces thyroid hormone. And this is a control. It's a systemic signal to the whole body that, controls metabolism. It's important in all stages of life, during growth, during puberty, during adolescence and adulthood. The needs of thyroid hormone change, and the body adapts to as a person grows. It also adapts to the environment, allows us to change our metabolic rates as needed during hot temperatures, cold temperatures, during food scarcity or not, or during acute illness. So it allows the whole body to adapt, and it keeps all of the different tissues and organs kind of in sync. It's a way of you might think of it as a conductor of the metabolic system of our body.
Nice. And so what kind of symptoms do people get when the thyroid's not working right?
Well, it depends. It depends on if it's overactive, if it's producing too much thyroid hormone, or if it's underactive, if it's not producing enough. And both kind of disease processes can happen. And everyone's a little bit different how they respond. But in people who are hyperthyroid, it tends to be a stimulatory response. People feel, their rapid heart rate, palpitations. People feel very tremulous or shaky. They can feel warm, sweaty, and anxious, and have difficulty sleeping. Now, there are other symptoms that can come upon as well, but sometimes they're a little individualized. Every person is a little bit different how they respond. And sometimes people can have these symptoms anyway and have a normal thyroid, which also can be confusing sometimes. But certainly when there's extra thyroid hormone around, these are the typical symptoms, and those are things to look out for.
And then what about when there's not enough thyroid hormone around?
Yeah, if there's not enough thyroid hormone, those symptoms also are unique, kind of individually unique, but there's a general trend, and that includes feeling more tired than usual, gaining weight, feeling cold, feeling kind of dry skin, and not able to concentrate as well. These again are very common symptoms and can be brought about by a number of conditions, or even just stress, or various other not sleeping enough, things like that. But thyroid function is one of the things. If there's not enough thyroid hormone around, these kind of symptoms can develop, and it's worth investigating if you have these symptoms.
Right. And I feel like that's what I see in the primary care office a lot. People come in, they have vague complaints of not being able to concentrate or remember things, or they sleep too much or not enough. We check a TSH, it's normal, and then we sort of move on with the rest of our differential diagnosis. Does that sound like sort of the right plan?
That's usually the right plan. The TSH, thyroid stimulating hormone, this is the kind of standard thyroid test. It's a hormone that's made by the pituitary gland, which controls the thyroid. We rely on the pituitary to sense if there's enough or too much or not enough thyroid hormone around, and it responds accordingly. It makes more TSH if there's not around, or it makes less TSH if there's too much. So it's a very reliable test, and it's kind of the gold standard in testing for thyroid. There are other tests available, and those should be individualized for the situation. Because most people have an intact pituitary, and the TSH is usually enough in most situations. I know there's a lot of literature about this, and there's even controversy in the lay literature as well as in the medical literature sometimes. But most societies and recommendations are to check the TSH, and that's a good starting point, and usually an ending point.
And what about for people who don't have any symptoms? They're just coming in for their physical or for something, unrelated. How do we know whether we should be checking a TSH on those.
That's another controversial point. I mean, it's usually
Hey,
included.
I didn't ask you here for the easy question.
It's usually included in a lot of the very standard workups or very broad, blood panels that are sent, but not always. And if you look at the guidelines that are put forth by societies, it's not clear. Now, thyroid disease is one of the most common, in fact, the most common autoimmune disease. Most of the conditions affecting the thyroid are driven by the immune system. And it affects, though, even though it's the most common, it affects maybe 0.3% to 1% of people. So most people don't have it. And so testing everyone, may not make sense. On the other hand, certain societies recommend, for example, the American Thyroid Association recommends checking every 5 years in people above the age 35. The American Association of Clinical Endocrinologists recommends checking people who are above the age of 60, or especially women. But there's not a rationale. I guess more women have thyroid disease than men, so perhaps that's the rationale there. But then there's other societies, like the Royal College of Physicians in London, don't recommend whatsoever, no testing whatsoever. So there's different takes on this, and it's as I said, a common problem, but it's still rare enough that maybe just screening everyone who's asymptomatic doesn't make sense.
And what do we do with the results? I mean, people who have no symptoms, we test them, and maybe their thyroid is like a little bit, their TSH, if normal, is like 1, maybe theirs is 5 or 8. How, what do I have to worry about that? And
Well,
what's
that's
the risk
also an
if I don't do something about that?
Yeah, it's another individualized approach. There's a study that came out now about 6 years ago looking at this level in people who are above the age of 65 and actually treated. They randomized people to be treated versus not, and it made no difference whatsoever if their TSH was just slightly high, but the rest of their thyroid hormone was normal, and they had kind of no overt symptoms. Nothing really improved. And so we think certainly in this group, it's not worth treating. What about people who are younger? Well, that's a point of controversy. And then, it can be considered if someone has a TSH that's slightly high, but have some symptoms, it's worth a trial of levothyroxine maybe for a few months, monitor for any improvements. And if there are improvements, it's reasonable to continue. And of course, if not, then maybe discontinue and continue to monitor. But, the follow-up is important in those cases. Now, what about young people, or certainly women who are either of reproductive age or are pregnant themselves? And in those cases, it's maybe worth treating. Certainly in pregnancy, even these mild high TSH levels are worth treating to avoid complications of pregnancy and various other effects that the thyroid can have on the growing fetus, growing baby. So, in those situations, then it's worth treating. But follow-up is important.
Yeah, that's so interesting. So in the non-pregnant person, I guess in their 30s and above, if we test somebody, they're asymptomatic, their levels are a little high, but their TSH is a little high, but the other numbers are normal. That's this like subclinical hypothyroid category.
Yeah.
And it sounds like, depending on how you talk through the pros and cons, you can treat them or not treat them. And if we don't treat them, when do you recommend getting another thyroid level?
Well, it's reasonable to check again relatively soon, which that means about 6 months. And if it's stable at that level, then maybe once a year after that. Of course, if it's changing, then either treat or check a little more frequently.
Do people's thyroid levels fluctuate a lot? I mean, whether they're normal or abnormal to begin with?
They do fluctuate a bit. So, it may go from 5 to 7 to 6 to 10. It can bounce around within that range, and that's normal. It even fluctuates a bit during the day. If you check it in the morning, the TSH is a little bit higher than if you check later in the day. And fasting has a small effect, but not that significant. But it's there. So there's fluctuation in TSH, so we naturally see that, and then that can be tricky. So if you check, say it's 5, and 6 months later you check and it's 7, is that really a trend on the upwards, or is it more just the normal fluctuation? You can't really say. It's worth checking again, maybe, or of course, if symptoms develop, then considering treatment.
And then the treatment that we talk about, I guess, is usually levothyroxine. We start at a sort of low dose. We check every 4 or 6 weeks, something like that, and sort of titrate it up based on the TSH. Does that
Yes,
sound
based
like
on
the right?
TSH and response um, and a symptomatic response of the person.
Yeah. Sometimes people want levothyroxine, even if their numbers are normal, because they think it'll help them think clearer or lose weight or whatever. Is there a downside to that?
There is. I mean, there's a risk of getting too much, of becoming hyperthyroid, and this is, medication-induced, thyroid
Right.
toxicosis, they call it. And that I've seen this happen, unfortunately, where patients are given either levothyroxine or some other supplement containing thyroid hormone, and for the purpose of weight loss or for some other purpose, and it can lead to, palpitations or irregular heart rate or other negative impacts on the patient. So we'd rather not try to avoid doing that if not.
Yeah. And then people sometimes ask me about some of the other thyroid medications to help, I guess, balance them out. Tell me about
Yeah,
that.
well, there are. I mean, levothyroxine is a synthetic version of thyroid hormone, of thyroxine, that is produced by the thyroid. But this is actually a pro-hormone. 97 or so percent, so it's about 97% of what's made by the thyroid is thyroxine. But a small fraction, about 3%, is T3, which is one of the iodines. There's 4 iodines, and one of them is removed. And the T3 is the actual active hormone. So the thyroid produces some of it, but there's also deiodinase activity in the liver or also other peripheral tissues that converts the thyroxine to active thyroid hormone peripherally. Some people need or feel that they need to take T3 as a way to treat their thyroid. And the jury is not in on this. There's a lot of study, and we don't have a good answer as to whether or not it's truly needed. There are certain endocrinologists that have very strong opinions that it is not. There are some that feel that it is, and it's a point of contention. And there are other formulations of thyroid hormone that have T3 and T4 combined. A lot of the natural products that are thyroid, desiccated thyroid, made from natural products, they also have a combination of T3 and T4. The downside to the T3 is that it's a hard medication to get the dose right, because it has a very short half-life. When you take it, it comes on immediately. The effects come on immediately, and they're gone, maybe 6 to 8 hours later. So you get a big spike of activity when you take the pill, and then it wears off later in the day. And so it can be difficult to manage that. You might say, well, take it twice in a day, but then you get 2 spikes. And so they're working on maybe a long-acting version of this, but that's not available now, and who knows? We'll see if that ever comes out, but it may. And in the meantime, treatment with the levothyroxine, we rely on the natural conversion slowly throughout the day to T3. And many societies either recommend this fully, or they strongly suggest use of levothyroxine to treat hypothyroidism.
Got it. All right. So we spent a lot of time talking about sort of thyroid function and the hormones. What if we talk about nodules for a minute? I feel like that must be a lot of what you do in the thyroid center. I mean, sometimes I feel something on exam, or a patient comes in and says they feel something. How do you approach that?
Sure. I mean, the thyroid nodules are very common. So these are, growths on the thyroid gland that develop with time. They're very, very common at increasing ages. There's a famous study that's now about 30 years old, I guess, that shows, about 50% of people actually have nodules above the age of 60, and it goes up with age. It's people who are age 20, maybe have about 10% of those that group of people have thyroid nodules, and so it goes up with age, and they're very common. Most of the time, they're growths that kind of hyperplasia growths that are self-limited. So they grow a little bit, they're thyroid cells, and they grow a little bit, and then they stop. Once in a while, they do represent malignancies, thyroid cancers that can lead to true cancerous activity and should be treated. And so a lot of the work evaluating thyroid nodules is one test if a person actually has thyroid nodules, and second, evaluating whether or not these are benign or malignant growths on the thyroid gland, and that can guide what you do with them.
So is there anything I can tell on exam when I'm seeing a patient to either reassure them or encourage them to go get further workup?
You can, on exam, you can palpate thyroid nodules. Usually they have to be, about a centimeter or so to be able to be palpated. If they're smaller than a centimeter, they're it can be hard to tell on a physical exam, even in the most experienced hands. But the good news is, if there's a thyroid cancer that's a centimeter or less, it's usually indolent. It's usually very, low risk to the patient. And the recommendations nowadays are not to biopsy nodules, even if they look suspicious at that size, just because, it leads to unnecessary treatments. Many times, these very small lesions are not a problem over the long term. And so I think a physical exam can be very reassuring to the patient. And of course, the follow-up to the physical exam is imaging, and the best imaging of the thyroid is thyroid ultrasound. So we do that in the thyroid center, and many experienced thyroidologists do thyroid ultrasonography because it makes a big difference. It helps to confirm the presence of thyroid nodules by ultrasound, and it also can help characterize the nodules. If we see findings on ultrasound that are benign, that can be very reassuring. If we see findings on ultrasound that are intermediate, well, that may help guide if we need to do a biopsy or other diagnostic tests. And if there's suspicious findings on ultrasound, that also can guide how we proceed. So ultrasonography is usually the best next test if you suspect thyroid nodule on the exam, and it can be very reassuring.
And it's a good test because it's safe, it's cheap, it's painless, it's easy.
There's no radiation; it's just sound waves. So it's a great test.
So it's a good test to do. And so then, how do you decide? I mean, you talked about this a little bit, but when you're looking at a nodule under ultrasound or by physical exam, how do you decide? What to biopsy and what's that like?
There are some good guidelines now. People have done a lot of work on this, on what about a thyroid nodule might make it look or appears more suspicious than others. And one of the things is the shape. If it's a nice round shape, that's more of a benign finding because benign things tend to grow in a round character. On the other hand, if it's more skinny and then kind of more elongated in other dimensions, that might make you feel suspicious. Or if the nodule, the border itself is a little bit irregular or even a lot irregular, then those can guide. If the nodule looks homogeneous throughout, that's a good sign. On the other hand, if it's heterogeneous and has a lot of blood vessels or blood flow, or if there's little calcifications, that can also be these are suspicious findings, and should be put together with the whole character of the nodule as well as the size of the nodule, and that can help guide if we need to do a biopsy. If we see that, we do a biopsy. It's not it's done by a fine needle, right, with ultrasound guidance, so we can see the needle going into the nodule and get some sampling of the cells of this nodule, and then they can look at these cells and tell us a little bit more about it.
And how long does that take? How painful is that?
Well,
how many times do you have to biopsy something?
It depends. If it's a benign appearing nodule on ultrasound and small, we don't need to biopsy it. It's only if we see these suspicious characteristics, or if it's relatively large, and large may mean about 1.5 centimeters, so about 3/4 of an inch, up until or if it has really very benign findings, maybe 2 centimeters, which is about 1 inch, or even larger as a size cutoff. And we may not even need to if it's a so-called cystic nodule, which is just fluid or mostly fluid filled. We may not need to biopsy at all, regardless of the size. So the ultrasonography can characterize that. It is a needle procedure, but in our practice we use anesthesia. Other places don't. There's trade-offs to using anesthesia and not. But I prefer to do it, and I think
you mean local anesthesia.
Yeah, local anesthesia, absolutely, local anesthesia, and then you still feel a little bit of a pressure with the needle itself, and there's a little bit of a recovery. It maybe takes about half a day to a day for the soreness of the procedures to go away. But it's really kind of a mild soreness most of the time, you feel it when you swallow, but otherwise it's kind of, you can continue on, with usual activities. There's no special changes that have to be done with the biopsy.
Got it. All right, and then take me to what's next. So depending on what you find, people sometimes need surgery. There are some other treatments they can get.
That's true. I mean, most of the time, most nodules are benign. It's just like, I think about 97% of thyroid nodules are benign. But the small fraction that are malignant ought to be treated in most situations. But there's some considerations there. If it's a very small thyroid cancer that's found within the thyroid lobe, there's actually a program called active surveillance where we monitor and see if there's any increase in size before sending a patient for surgery. On the other hand, if it's larger, or if there's other features, maybe there's evidence of spread already, we may see this in lymph nodes in the neck, then we would recommend surgery. And then there's surgery, there's a decision for surgery. What type? Should we have a total thyroidectomy, removing the whole thyroid gland, or maybe just a hemithyroidectomy, removing if it's a smaller nodule and we have reason to think that this is a less aggressive thyroid cancer. Then a hemithyroidectomy is often curative in those cases. Thyroid cancer, it's one of the top 10 cancers in prevalence, but many times people do very well, but sometimes there's not. It certainly can spread, and so the course of treatment, we're trying to tailor to the course of the aggressiveness of the cancer itself. So most are not so aggressive, but some are, and so that can help tailor the course, how we treat the person. In the more aggressive cases, then we would go with a total thyroid surgery, and even a lymph node dissection of the neck if there's evidence of spread to lymph nodes. And then if there's evidence for further spread, which there can be, it's very, it's not uncommon. I mean, it's not common for there to be a lot of spread, but there could be. And if there is, then we have other treatments such as radioactive iodine or such as other directed therapies, depending on what is actually present.
Great. All right. Well, thank you so much. That was really a whirlwind tour of the thyroid gland. And one of the things I love about your thyroid center is how closely you work with the pathologists, the head and neck surgeons, ENT, and all these other folks in the building to make sure people are getting the kind of unified care that they need.
Yeah. Yep. So we have a comprehensive thyroid center. We have excellent surgeons. We have excellent pathologists. Our radiologists are excellent in nuclear medicine, and we meet twice, 2 different thyroid tumor boards each month where we meet and talk about difficult cases or cases where a decision is not fully clear, but want to get everyone's opinion. And what's great is that we're able to review all of the data from, right from the horse's mouth, from the people who read the studies. They read the study again with us and go over findings and can help come to a consensus in difficult cases. And in addition, we have regular meetings to talk about the latest thyroid scientific developments and publications. So we all try to keep abreast of this developing field as it's moving very quickly with very specified molecular targets for certain types of thyroid cancer and certain mutations that are found within some thyroid cancers. So it's a great field to be in. It's a very exciting time in thyroidology, and we have as you mentioned, a very comprehensive team, which is a team approach to the patient.
That's great. Well, thank you for all the work you do. Thank you for joining us today, and thanks everybody for joining us.
All right, great. Thank you. Bye-bye. Have a good day.